press the right button. Okay, members, welcome to the BCP Health and Wellbeing Board for the 15th of July. I'm Councillor David Brown. I've been Chair of Health and Wellbeing Board for the past year. We've got quite a lot on our agenda today, so I'd just like to welcome you all for coming along and thank you for turning up this afternoon. Could I just ask for our Democratic Services Officer to go through the housekeeping rules?
Thank you. Please note that this meeting of the Health and Wellbeing Board is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. This meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chair in case of disruption. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the assembly point in the War Memorial in the gardens opposite the front of the building in Bourne Avenue. Finally, please ensure background noise is kept to a minimum. Mobile phones and other devices are turned off or switched to silent for the duration. Thank you.
Right, thank you for that. So I'll now move on to the agenda items of the meeting. We'll start off with the apologies and substitute members. I will actually, once we've done this bit, go around and ask for introductions because I think there's probably a few people here who haven't met others, and it'd be useful just to do that, sort of, to go around the room. But firstly, agenda item 1 of apologies.
Thank you. We've had apologies from Councillor Kieran Wilson, Graham Farrant and Patricia Miller.
Thank you for that. And do we have any substitute members?
No substitutes, Chair.
Right. Okay, thank you. Agenda item 3 is election of chair. We've come round for a year of the meeting, so we're round to election of chair and vice chair. So as chair, I can't really handle the vote on myself as election of chair. Could I ask Gillian for you to?
Thank you, Chair. Can I ask for nominations for the Chair of the Health and Wellbeing Board? Councillor Burton.
Yes, thank you. Could I nominate Councillor David Brown as last year, please?
Are there any seconders for that nomination? Thank you.
Yeah.
Seconded.
Okay. No other nominations? No.
Duly appointed. Thank you, Chair. Over to you.
Nominated and seconded, unopposed. Good. That's how I like it. Great. Thank you for that. So I'm very happy to sort of continue in the role of chairing the Health and Wellbeing Board. And we'll go on to item 4, election of vice chair. I'd like to propose Patricia Miller in her absence. She's sent her apologies and can't be here today, but she's communicated that she's happy to be proposed as vice chair. So I'd like to propose her as vice chair. You would like to second? Gillian, would you like to second?
I'm happy to second.
Thank you. No other nominations for vice chair? No. Okay. Patricia's elected as vice chair for the coming year. Great. We'll move on to agenda item 5 now. Confirmation of minutes. They've been circulated with the agenda papers, the minutes of the last meeting, which was a few months ago now. Is there anybody got any comments or amendments that they'd like to see to the minutes of the last meeting? I did have a look through and it all seemed okay to me. It was from the 5th of February. No? Okay, if everybody's content with that, then we'll take that as consensus to confirm the minutes of the last meeting. I'll sign a copy for the records. Agenda item 6, any declarations of interest? Do any committee members have any declarations of interest? If they can indicate now. No, okay. If there's anything that does crop up during the meeting and you feel you've got any sort of personal or pecuniary interest in an item, then please raise your hand and state it at the time. Any public issues?
There are no public issues, Chair.
Public issues, great. Right. Just as I said, just before moving on to the main items of business, we've got quite a lot on the agenda today. I think because the last meeting was cancelled, so we've got 4 or 5 sort of main agenda items to get through today. I'm hoping to keep the meeting to 2 hours and conclude by about 4:30. So I know quite a few other people have got further meetings later in the day as well. So we'll try and keep to time as best as we can. But please feel free. We've got quite a few interesting items on the agenda to sort of raise any questions or discussion points on any of the items. As I mentioned, I think it'd be useful just to go around the room just to do introductions, because there's a few sort of different people in the room to normal. I'm Councillor David Brown, portfolio holder for Health and Wellbeing at BCP Council and Chair of the Health and Wellbeing Board.
I'm Gillian Kay, Corporate Director for Wellbeing in BCP Council.
Hello everyone, I am Cathy Hadley. I'm the Corporate Director of Children's Services for BCP Council.
Good afternoon, I'm Siobhan Harrington. I'm Chief Executive at University Hospitals Dorset.
Hello, I'm Matthew Bryant. I'm Chief Executive at Dorset Healthcare and Dorset County Hospital.
Good afternoon, Nick Johnson, Chief Strategy and Transformation Officer at Dorset County and Dorset Healthcare.
Hi, I'm Amy Gallagher. I'm Community Initiatives Manager at BCP Council.
Good afternoon, everybody. My name is Alistair Doxic-Purser. I'm the Chief Executive of FaithWorks, a local charity, and I'm the Chair of the Access to Food Partnership in BCP.
Good afternoon, everybody. I'm Ashley Boreham. I'm the Deputy Chief Transformation Officer for NHS Dorset.
Good afternoon, everyone. I'm Karen Loftus. I'm Chief Executive of Community Action Network, here for the voluntary sector today.
Hello, everyone. I'm Councillor Richard Burton. I've got the Children's and Young People's portfolio of BCP Council.
Great, thank you everyone. I think that was useful just because I know there's different places or people that haven't been to the sort of meetings for a while. We'll move on to then the first main item of business, agenda item 8, so the update on the joint working in health and integrated neighbourhood and community teams programme. So yeah, could I invite Nick Johnson, as the Joint Chief Strategy Transformation and Partnerships Officer for Dorset Healthcare, to present this item?
Yeah, absolutely. I'm going to load up some slides onto Teams in a moment, but while I do that, I'll pass across to Matthew just to do some introductions.
Great, thank you very much, Nick. So from my point of view, it's really great to be here today and to be able to talk about this topic. And I would also like to say that a colleague has been representing me recently at this board meeting, but it would be my intention to attend in the future. So I'm really pleased to be here today. What Nick is going to talk about really is the work that we're doing between Dorset Healthcare and Dorset County, where we are changing the way the organisations are working together, but very much in a way that's focused around meeting the needs of the person or the citizen. We're doing that in the context of the ambitions of the integrated care system within Dorset, but also all of the relationships that we have. So the relationship we have with UHD, which is incredibly important, and the BCP local authority, and then as importantly as that, to go on to describe the integrated neighbourhood team programme, which I think is a very timely and important and exciting programme of change, which again we can only do if we're all working together in terms of the landscape of health care, but also the BCSE. So I'm not going to steal any more of Nick's thunder. I'll pass across to Nick and then we'll have the discussion afterwards.
Thank you, Matthew. So I'm just going to talk through some of the slides. As Matthew described, I'm going to talk about two elements. One is how Dorset County and Dorset Healthcare are working together and what that means and what we've been doing. And then the second part of the presentation is just around the integrated neighbourhood teams programme, which is in development. And then we're really happy to take any questions as well. So just very briefly, Dorset County Hospital serves over 300,000 people in the west of the county. We are the acute secondary care provider for that part of the patch. We've got about 300 beds, 10 operating theatres, and we also do outpatients as well as some cross-county services such as renal. And we're also in the new hospital programme, where we're currently in the process of building a new emergency department and critical care unit as well, which means that hospital will have the facilities to provide that service for now and for future generations as well. Dorset Healthcare provides community and mental health services across the 800,000 residents in Dorset, about 7,000 staff across a whole host of sites. We provide physical health, which includes all of the community hospitals, district nurses, school nurses, sexual health, audiology. We also provide mental health learning disabilities as well, which includes inpatients, CAMS, eating disorders, etc. And we are also part of the New Hospitals programme. Some really exciting work for a CAMS PQ in Bournemouth and inpatient facilities at St Anne's in Poole as well. I know a lot of you will be aware of all of the work that Dorset County and Dorset Healthcare do, so I won't say any more, but I thought it was just useful to set that scene. We have been working together for about 18 months, coming up to 2 years now. Initially, we agreed a new leadership model between Dorset County Hospital and Dorset Healthcare, which was really to help the boards simplify decision making, increase integration and improve quality and outcomes. It is a means to an end rather than an end in itself. The challenges that we face across our two organisations and the challenges that we all face around increasing demand, limited workforce, limited finances can't be solved on our own. We are much better placed to solve those challenges and to work on them by working much more closely together. And this partnership is one way that we are looking to do that, with a real focus on preventing ill health, tackling health inequalities, looking at how we can integrate physical and mental health more effectively, and really thinking about how we join up workforce planning and development as well. But as Matthew says right from the outset, and as someone who was involved in those very early discussions, we were very clear that this wasn't a mutually exclusive partnership. This was something that would help us work better together, so we could work better with all of our partners across the health and care system. And we've tried to absolutely stay true to that word. In terms of the journey that we've been on, as I said, around about March to December of 2022, we started having these conversations, and an agreement was reached for the shared leadership model. That started with recruiting a joint chair and a joint chief executive, and Matthew joined us in April of 2023, and David Clayton-Smith, our joint chair, joined us just after in May 2023. At that point, we established a working together program, which really looked at how we could identify a number of key areas where we could work more closely together. And we built that over a period from May to September of 2023. So we were collaborating and working in partnership in areas that we'd identified, looking at collaboration by permission, I think is fair to say. What we've now moved towards as we move into the next phase of the partnership is something that we're calling our federated model. That's much more around collaboration by default, doing things once where it makes sense to, and really thinking federated first as well. And we've got a number of new models that are being developed as well. And what we've got in place effectively is the joint chief executive and chair. We've got joint chief officers, so my role, our chief finance officer, chief people officer, which enable us to look at how we deliver corporate services and enabling services differently across the two organisations. We've just built a joint strategy, and we're really starting to think about how we build a shared culture around that as well as looking at governance arrangements. In parallel to that, we've been developing clinical case studies and looking at the way that we work together in places like diabetes and frailty and children and young people's as well. But they have not been bilateral, they've been very much multilateral, and looking to include all of our partners across the system as we work on those models. And we see them as opportunities to develop new pathways and new ways of working, which can be rolled out across the whole of the Dorset system as well. And on that note, we come on to the integrated health and care neighbourhood teams, or integrated neighbourhood teams. Now, the integrated neighbourhood team programme is very much about how we across health, because we know that within health we work quite often in in a siloed and fragmented way. So it's very much about looking at those health teams across community and primary care in particular, and thinking about how we can work in a much more collaborative and integrated way. And Dorset Healthcare, along with the GP Alliance in Dorset, have been trying to drive forward this programme with partners, and really then thinking about how we can work closely with our local authority partners in that integrated neighbourhood team space as well. So in particular, thinking about how we work across health and care teams. So you get to a point where you have integrated health and care teams at a multidisciplinary level within neighbourhoods and communities to meet the needs of the population, rather than designing services around organisations. And that's very much the ethos that we're trying to take forward with this programme. It's been, I think, an interesting conversation as we've been through this to really define it. This slide really tries to pull out the fact that the integrated neighbourhood teams programme is one element of the wider place based approach that we know that we need to take across the health and care system. So it's not about solving all of the social determinants of health. It's not about the really important work around building stronger communities. The integrated neighbourhood teams programme itself is about how we bring those health and care teams together so they can work differently to meet the needs of the population. And that's I think a really important factor just to pull out in terms of this definition. And what we're really thinking about or looking to do is build teams where we can streamline access to care and advice for people who get ill but only use health services infrequently, so we can provide people with more choice about how they access care. We're then thinking about how we can provide more proactive, personalised care with support from multidisciplinary teams of professionals to people with more complex needs, particularly those with long-term conditions. And as well as that, thinking about how those teams can help people stay healthy and well for longer. So this is very much about thinking of the resources and the capabilities that we've got in localities and in neighbourhoods, and working differently to be able to better meet the needs of the population. I'm not going to read out the slide in any detail. The point I just wanted to pull out here is that there's a clear plan that we're working to really think about how we can roll this out across the whole of the Dorset system as quickly as possible. We recognise the opportunity that this provides and the benefits that can be that could be brought, but also it's a potentially large scale change, and therefore we have to manage the rollout and the implementation in a measured way. But we want to do that in a pacey way as well, because some of the impacts of this new way of working in terms of improving people's health and well-being, in terms of reducing demand into acute services, is really, really important for us. A number of the other challenges and number of the other programs that we've got across the health and care system. So that's just to pull out that point. And then the final point just to pick up on is, I know certainly there have been some conversations already around what that might mean in terms of the neighbourhoods and communities within the BCP area, and working closely with local authority colleagues, ICB colleagues and others. We've looked to see how we can map that out to try and build neighbourhoods and communities which fit around some of the natural communities that we know we've got within the area as well. But this will be, as is the whole programme, a really iterative conversation to really make sure that we're listening and hearing back from partners and residents and service users as well. So in summary, a really exciting programme looking at how we can build teams of teams to meet the needs of the population. Absolutely commitment to working across all of the partners and across the system to deliver this. Really tricky conversations to be had around given the complexity, but a real commitment to be able to do this and to keep that ongoing dialogue. Because if we do that, we've got a much better chance of delivering some really significant change to improve the way that we deliver services as well. And on that note, I come to the end of the presentation. I've tried to cover a sort of a huge amount there, but hopefully given you a good flavour of it, and we're really happy to take any questions.
Okay, members, I think it's our role to well, the action is to note and comment on the implementation of the integrated neighbourhood teams. And yeah, just any comments initially, any sort of thoughts or responses to what Nick's presented there. So, Gillian.
Thank you, Chair. A couple of comments and also a question for Nick. So the comments on the integrated neighbourhood work, I agree this is a really, really exciting programme. I want to thank Matthew and Nick and also colleagues in the GP Alliance for their leadership of the work on this so far. I think the opportunity for us all to really test and challenge ourselves as to what it means to organise our work and our functions around communities rather than the other way around is a really important challenge, and we've been engaged in it and involved in it so far, and really keen that we are working closely as well with the voluntary and community sector on this, because they more than anyone can help keep us honest about what it means to work with natural communities. A couple of points that have come out of those discussions that I want to make sure that board members are aware of. We're really delighted it's been agreed that the Health and Wellbeing Board will perform an important governance role in the BCP place around this programme. So I think this is the first of many updates that we'll take on it as a board. Also, that we're starting to explore in terms of how those teams will be organised using wards as a footprint, whereas in the past I think PCNs have been the sort of principal building block, and I think that's, you know, wards are not themselves natural communities any more than anything. They're an administrative construct, but they're one that I think we recognise and work with in our place. The question is going back to the federated structure in Dorset County Hospital and Dorset Healthcare. And just a question really, I mean, I see very clearly for the system the logic to bringing those two organisations together and making good use of resources for the benefit of communities. But I want to ask for the board and for residents really, what assurances can we have that for the BCP place and for that the organisation doesn't become balanced towards the west simply by the nature of that federated structure? So I wonder what assurances you can give us around that.
Shall I answer, and then you can pick up on anything else, Matthew, that I don't cover. So I think we've been very conscious of this because it's something that was raised right at the outset, and I think rightly so. So we have been really mindful of it. I don't think we've seen any shifts as a result of the partnership towards the west of the county so far. So I think there is something about actually we're not seeing this play out, but that's not to say we're sort of complacent or dismissive of the point. I think the second thing I would say is that within the federated model, we retain the two trust board structures. So while we're working really closely together, looking to do things once where it makes sense to do so, actually we have been really clear that the statutory function of the two trust boards remains, and they meet separately, and they have trust specific non-executive directors who are solely focused on that. And then thirdly, in terms of the way that we've constructed the executive function within the organisations, while we have shared roles, we've also got organisation specific roles, and really specifically the chief operating officer and the chief medical officer, whose role and responsibility is absolutely to make sure that those organisations are delivering against their licence. And I think that puts a level of healthy tension within the conversations that we have within the executive function. So I think there are a number of safeguards there, but I may well have missed something, so I'll just look across to Matthew to see if there's anything else.
Thank you, Nick. I haven't got a great deal to add to that, apart from to, I suppose, just reflect about the relative size of the two organisations. So I think so what we've got is Dorset Healthcare employs about 7,000 people, and Dorset County employs about 3,500 people. I think if it was the other way around, the risk that you're describing would definitely be there. I think with that size balance and Dorset Healthcare's focus very much as an integrated care system wide provider, it really helps to mitigate against that. In conjunction with partners, we will be looking at a number of other metrics which really are associated with whether we are delivering our system strategy. So that includes where we're spending our money, as an integrated care system from a health point of view. So what proportion goes into acute care, what proportion goes into mental health and community? And clearly that's another safeguard in terms of the question that you're asking about ensuring the balance of Dorset healthcare. And I think if you look at our strategic programme of change, there's a lot that we're doing, and that includes actually the other investments and change in the BCP area, with £75 million of construction investment going into mental health services based in BCP as the only standalone mental health programme within the new hospitals programme. So that's really significant. But in terms of the sort of leadership focus that we've got, I would say we're giving more time to the integrated neighbourhood team programme than anything else. And the integrated neighbourhood team programme is rooted in those communities, and it's about doing that equally across the integrated care system.
Siobhan.
I wanted to say that it was really good to hear the presentation. Actually, it's probably the first time I've seen it all sort of together. And actually, the integrated care team development, the neighbourhood teams, I think it's really important probably just to flag that as these evolve and develop, I would hope that all of us in the system really lean into this, because the changes that are happening across University Hospitals Dorset over the next 18 months to 2 years actually do need these teams to be operating and functional in place across BCP and across Dorset Council. So actually from UHD, we're very much wanting to be very actively engaged, but I also think it's a real opportunity for us to look at probably the timeline currently, because I would just say that actually it would be good if we can think about how do we really escalate some of that timeline. As I go through some of the changes with the hospitals, you get to a point where actually it's really important that we do these changes as safely and as speedily as we can, because actually on the other side it will be much better. So I just sort of probably make that plea here, especially around the governance with the Health and Wellbeing Board. I think we play a role in trying to maintain the momentum around what we're doing to make it better for residents.
Any other comments from any other board members? I've got a couple of comments myself, but I'll give others a go before I jump in. Yeah, I mean, a couple of comments. I'm pleased you sort of clarified the point in response to what Gillian said about the sort of focus of the sort of the federated body. And I suppose there's a role there for the Health and Wellbeing Board, also just to sort of, you know, keep a watching brief on that. And I know you'll be attending both the Dorset Health and Wellbeing Boards and our BCP Health and Wellbeing Board. But and I'm quite reassured really by what you say, and particularly about your sort of investment in mental health services within sort of BCP, which is very significant. My comment on the integrated neighbourhood team programme and the roadmap that's there, and I think it's interesting and it's useful to have that more sort of ward-based sort of map, as opposed to sort of, if you work from a system point of view, you look at the GP practices and you work from there, and that's not really a sort of natural community, the sort of GP networks. But it's quite an ambitious rollout programme, looking at effectively over the next 9 months, really, isn't it? To sort of, so pretty much every week, really, you do sort of, or every couple of weeks over the coming 9 months, you're sort of having new integrated neighbourhood teams sort of coming on board, which I'm sort of reassured from what Siobhan said fits in quite well with where UHD are coming from. But I'm guessing, you know, this you're rolling out these integrated neighbourhood teams, but it will take a while for things to shift and to bed in, and for people to get used to different sort of roles and structures and reporting lines, etc. And just in terms of sort of risks around that, I'm thinking particularly, I suppose there's risks in terms of delivery and as things bed in, but also just in terms of safeguarding and ongoing sort of cases as teams shift and maybe people's responsibilities and patches shift. Is there any sort of assessment of sort of any sort of safeguarding risk where potentially somebody, you know, could drop the ball in terms of particular cases or people's ongoing care or an ongoing support?
Yes, so certainly within the programme structure, we have a focus around that. I think we're in a place where we're looking at the effectively how do we implement these new models, and therefore we're in active conversations about how we mitigate those sorts of risks. So I think it's a sort of a timely question reminder for us to really stay focused on those safeguarding issues. My expectation is that we have a transition which minimizes and which enables us to continue to deliver the current case studies in the way that we need to, while also moving to those new structures. And that's not something that's going to be easily done, and we have to manage it as we go along. But it's a good question that we'll need to pick up on.
And just to supplement, I would say 3 of the strategic risks that we face are about the engagement, because it's a very big program of change, workforce, and I think within the context of health within the integrated care system, getting diverted by some other crisis is always a risk. So it's about how we maintain focus. And that's really hence the project infrastructure that Nick has described. In terms of your specific question about safeguarding, so I chair the programme board, which I do jointly with Forbes Watson, who's the clinical chair of the GP Alliance, and we're the senior sponsors for the work within the system. I don't see that safeguarding would be a risk in the way that you've framed the question. Right. However, I think that is a good question to take into the programme board setting and discuss. So I will take from this discussion and put it on the agenda of the next programme board to see if anybody has a perspective that I'm not seeing myself. And then I think in relation to the speed of the programme, well, I think between your question and Siobhan's comment, you've sort of described the tension that there is there, which is this is very important, and the sooner we can do it, the better. And it is a big programme of change. And all the evidence from elsewhere around the country would suggest that this is a programme of change that takes, people talk about a multi-year programme of change. I know, Siobhan. They talk about giving the time for these teams to develop and grow before judging the outcomes, because this is not, as a metaphor, it's not like a machine that you're constructing and then you hit an on button and it works from day one. It's far more of an organic system that we need to grow together. And so I think my plea, aligned with what Siobhan has said, is for everybody to lean towards this and please get involved. This is not something Dorset Healthcare can do alone. We need this to be a collective effort, but we also need to have the confidence to give this the space and time to embed before we judge its delivery.
Yeah. Thank you for that. Yeah. Any other points or comments? If not, I think, yeah, it's for us to note and comment. Obviously, we've made comments on it, and for the Health and Wellbeing Board to note that. So thank you very much to both of you for sort of that presentation and those responses and reassurances, I think, in terms of the sort of questions that have been raised.
Thank you.
Thank you very much. And I think we're still just about on schedule. Actually, I'm trying to keep the schedule so that we move through things. Okay. Agenda item 9, the NHS Dorset Joint Forward Plan for 2024-25. Ashley, I understand that you're here to present this, so grateful if you can present this item, and then we'll have any sort of other questions. Again, it's another one, it's requested for our board to sort of note, but yeah, any other sort of comments. Thank you, Ashley.
Thank you very much indeed. So I've just managed to get up on my screen, so that's the first technical problem solved. So the Joint Forward Plan, and there might be a bit of delay. There's a bit of comms on the, so it's coming up. There you go. 100 conversations. The journey started with all of us as a team over a year ago. There's 100 conversations, linking with the communities and really listening to what the communities want in how we design this together as a plan. We have moved on now in terms of the context. we put this together and published it in July 2023. We're now just a year down the line, and what we were required to do by the NHS England was to undertake a refresh every year of the plan. There are no fundamental changes. If we had fundamental changes, we would be required to go out to consultation and re-engage all our partners. But what we've done here is we've now had this opportunity to look back and the progress we've made to date and the impact we've made as we move forward on our communities. In setting the context, the plan hasn't changed. The front end of the plan sets really what we said, outlines the geographics, the population across the whole of the system, describes it, because this is a people-facing document. This document is about our contract with the people of Dorset. So it's really written in a way that really ensures that we've understood them in those conversations and how we're laying out our plan. But the main body is the 5 pillars. And in the 5 pillars, which I'll describe later, we focus on what we've been doing, what we're going to do, and how we measure our progress, and more importantly, the impact on the people of Dorset. Each pillar will show is broken down into a year 1 to 2, a year 3 to 4, and a year 5+. And the kind of that conversation is, as described by my colleagues on the other side, that some changes take a bit of time, and some things we need to maybe increase the tempo on. And we tried to identify that in the plan. There are enabling plans that weren't there before. So things like infrastructure, digital, clinical, which we promised we would deliver in year 1, which we have then written, and they are now part of the plan and are now available. There's also broken down into the document, it talks about the governance in simple terms, so the people of the Dorset understand how we integrate with health wellbeing boards and how it all comes together. Also the risks at high level. And what we've done this time is we've introduced case studies. So we've hyperlinked case studies that will be live all the way through the next year. So for instance, if we start to look at things like creative health as a new strategy that we want to do in Dorset, we then show and demonstrate what's going on in the moment in BCP area. So we link to Pavilion Dance and show them what's going on with the Parkinson's dances, and really show those case studies to show that we're actually what we're doing, because this document is about a live document that we live by and make sure that we progress the system. So what we need to do to transform the 5 pillars to meet the expectations of the Dorset citizens, the objectives of the ICB. We need to do this. We need to shift from a health perspective to a dual system working, focus on true drivers, poor health, inequity, and optimal life outcomes. We've discussed before, prevention is fundamental to this. Currently, we're spending less £1 in every 100 on healthcare. And we need to move those dynamics, because we need to move into the place that we shouldn't be waiting for people to get ill. We should be upstream engaging with those populations. And I was really grateful for Matthew and the team going before, because actually one of the things about these integrated neighbourhood teams is about the engaging with the communities and understand the community's needs. And therefore that absolutely chimes with what we're talking about here. But also must make sure that our outcomes that we do are smart and they matter to the people of Dorset. In terms of making Dorset the healthiest place to live, the ICP strategy and the 5-year plan hasn't changed significantly. We still have, here we've got a model of the Greek temple. It shows, in effect, the strategies at the top, the 5-year plan, health inequalities running across the piece, and the 5 pillars that we wrote into the plan as a team together, which was improving the lives of 100,000 people impacted by poor health, preventing 55,000 children from becoming overweight by 2040, reducing the gap in healthy life years from 19 years to 50 years by 2043, increase the percentage of older people living well and independently in Dorset, and adding 100,000 healthy life years to the people of Dorset by 2033. Underpinned by those I described earlier are the estates plan, research, transformation roadmap, people plan. All those things are key enablers to make sure that this works. In terms of transformation across the health continuum, the key principles are understand the impact of interventions on health inequality in terms of access, experience and outcomes. We want to reduce unwarranted variation in the system. So therefore everybody, even though across the Dorset, everybody should have the same outcomes and there should be no variation to what they receive within wherever they live, within in a ward or in a community, town or in the country or on the coast. We're focusing on really primary prevention, secondary prevention and optimization of treatment. But as I said earlier, it's about increasing tempo. And increasing tempo is about where the things that will have the immediate demand on our population, reduce the pressures on secondary healthcare in the acutes, and make a difference to the people of Dorset. And that is probably in secondary prevention. Understanding unmet cases out there, proper diagnosis, managing conditions, and working with our partners. So it's not just about medication, it could be healthy lifestyle. It could be working with our partners in the third sector and understanding about the other things that matter to those population. And also ensuring that all our outcomes and metrics are evaluated. And how we're doing it is we're still focused on prevention of population outcomes.
Just a moment, actually, sorry, just in terms of the actual presentation slides on.
Not shared.
I've got, so it's going live over the system. So I only can imagine at the moment, I apologise, but I think if I've lost connectivity. Yeah, so I'm going to rejoin. Sorry, I'm going to rejoin the call.
Yeah. Stop sharing and then try sharing again and see if that works.
Okay.
I think members have all had the presentation sent out with the
have, yeah,
pages anyway.
So if it doesn't work, it's fine. But
yeah, it keeps dropping in and out.
Okay, that's fine. Let's sharing online. Carry on.
So here we go. There we go. We're back on blue screen. Thank you. Okay, but secondary prevention. And the other thing also is important that the outcomes, the metrics are evaluated. It's not just what we do. We evaluate what do that impact and understand what that's really doing. We talked about those outcomes, data-driven, shifting from low value to high value investment, really making sure that those that we talked earlier about, actually the money we put into the community can make a massive difference, shifting resource allocation and working together and creating networks. And the networks are really important because we talked earlier about the importance of moving from hierarchical organisations to networks. And also Matthew talked about engineering. Healthcare is complex, not complicated. Engines are complicated. Healthcare is exceptionally complex and is an ecosystem that relies on people working together in really clever ways. And so the whole of the system needs to move into that kind of way of working. But actually, we've already got really good examples. We're not starting from the ground zero. We've got integrated models of care already in place and at place. So we've got partners here from the third sector already working in communities like Blandford. We've got self-management in place. We've got Live Well Active Dorset. We've got hypertension management systems and apps out there. So all these things are in place, and some of our networks are quite mature. There's some excellent work being done in the respiratory network already, reducing asthma and admissions, and that's working with Live Well Dorset and Active Dorset as well. So what we're doing at the moment is actually building upon the successful work we've done before. So that kind of tempo is already there. We just need to make sure that we learn what we've done, improve what we've done, and then set up more networks as we go forward and shift investment to where it has high value. The plan itself was held back because of the general election on guidance, but it went live this morning and it was published, and I've already released it to Louise, and hopefully it'll be on your website as we speak. So it's now accessible to the people of Dorset, a live document. But I would take on board that as we go through, there's an opportunity for deep dives of this board to go and look at this plan and really examine and ask questions. How fast are we going on those areas? Can we do more? And really hold us to account to make sure that we're doing what we say in the plan. I'm taking any questions from the floor, and I apologise for the digital mishap.
Great, thank you for that. Yeah, any questions from board members?
Yes.
Karen, do you want to?
I could just talk to you, couldn't I? But then no one could hear me. I'm just looking at the last slide, which is quite, I think it's worth reading it out. those areas that spent relatively less on community care in terms of population needs have seen a higher than average levels of hospital and emergency activity compared with those spending relatively more. On average, systems that invested more in community care saw 15% lower non-elective admission rates and 10% lower ambulance conveyance rates, both statistically significant differences, together with lower average activity for elective admissions and A&E attendances. I'd really like a word with who wrote that, to be frank with you. Could have made it a little bit plainer, but I think I get it. I think we all get it in that, you know, historically, those of you who know me have been banging my drum for preventative care and going upstream for what feels like a really long time, Ash. And, you know, but it's true. It does actually make a huge difference if we can do this. And I know these are numbers, but actually these are people. These are our mums and dads and aunties and uncles and me and you and, you know, having to go into hospital if you don't need to. If you really don't need to go in, I really don't recommend that you do. Not, no disrespect to your hospitals, they're lovely. But, you know, if we, you know, to be honest, if we can prevent it, you know, my own experiences with my dad bouncing in and out to hospital was horrendous for him and me, and it didn't need to happen. So I think if we can look at how we invest in our communities and let our communities be the agents of change, I think that would be an absolute winner for us all. Thank you.
Thanks for those comments. Ashley, I don't know if you want to respond.
No, it's absolutely true. We, you know, unwarranted cold case finding, hypertension levels in Dorset need to be better. Working with our people out there, understanding and getting those people with hypertension, high blood pressure are managed. Working with people in getting people more active, identifying that, reducing demand and keeping people well in their home absolutely is the right thing to do. And my acute colleagues absolutely want to see reduction in demand because it means that they can focus in their hospital on the things that are really important, because those hospitals are amazing, but we don't need to have people that don't need to be there, and we can deal with those in the community. And the really great thing about the integrated neighbourhood teams is that's one of the real key enablers that we're working with our partners will start to make that difference and really help prevent people from being admitted into acutes and keeping well in the community.
May I just very quickly respond?
Yeah.
Okay. Yes. But people, I think our language also, we need to check ourselves in our language. People should want to be well and healthy and take responsibility themselves to be well and healthy. It's not up to us. It's up to us to create environments for community-led empowerment, not to keep people well, but for people to want to be well. And we put things in place that help them to be well. And because people mainly live in communities and families, you know, and that is where your solution lies.
Thanks for those comments, Karen. I've got next Sam online.
Thank you very much, Chair. Hi, I'm Sam Crowe, Director of Public Health. I'm sorry I can't be in the room with you today. Can you hear me okay?
Yeah.
Ash, thank you for taking us through the presentation, and it's really helpful to understand that the detailed plan's been published now, and I understand it probably be helpful to kind of revisit that when we've had a chance to look through it in more depth. So my comments are sort of more aimed at us trying to find the right topics for discussion that provide the link between some of what might appear in the refreshed health and wellbeing strategy in BCP Council and some of the work under the 5 pillars and the 5 outcomes. And personally, I'd like to see a little bit more clarity and progress on what's happening under each of those 5 pillars. It will be really important, I think, for the Health and Wellbeing Board to have clarity on how far that work's progressing, not least because the chair is regularly asked by NHS England what's been the contribution of NHS Dorset to meeting some of those Health and Wellbeing Board priorities. So when we kind of move on to discussing things like the forward plan, it would just be good to have more clarity on perhaps more specific topics and areas where we can sort of join up, if you like, the work between the Health and Wellbeing Board and parts of that NHS Dorset joint forward plan, because totally accept the point that this is long-term work, but it's been a year, and it would be really good to start to unpack and unpick more specifically what progress is being made in those aspirations around prevention under the 5 outcomes.
Yeah, thanks for that, Sam. That's a useful comment, actually. I'll ask Councillor Burton to come in next, just actually.
Yes, thank you very much, Chair. Yeah, I mean, I'm following on from these conversations. I'm very interested in the looking at the prevention work, and of course, from my point of view, prevention always starts with children and young people. I was interested in looking at the 5 pillars, because as soon as I looked at them, I thought, well, where are children in here? And then, of course, I found things about children in there, which I was really pleased to see. There's a couple of points. So the 100 conversations at the top. How many of those conversations, I'm not expecting an exact answer here, but were children and young people involved in those conversations, and did their voice get fed in to those 100 conversations? And likewise with the 5 pillars, for me personally, it will be really useful to see the children and young people's thread in there, to see where that work is happening. I mean, I can see a few of them, it's not actually pertinent to children and young people, potentially older people, but a lot of the other pillars are, and it would help me, I know, to understand where that work was going.
Thanks for that. Ashley, any?
Yeah, I think, when I made the point, absolutely built on the point earlier, there needs to be those deep dives and that understanding, because some of the work we're talking about here cuts across all of them: healthier lives, earlier start, healthy weight, all the way through, the maternity piece. All of those things play in. I think there'd be a great opportunity in supporting yourself, and what Sam said is to bring back and hold us to account and show where we made progress on those areas. Some deep dives in some of those areas of a particular interest to the board, and that's great, because it's really important for us to bring those back, because it helps us make sure that we maintain that tempo on delivering against the things that we said we're going to deliver in the plan. It's really important. So I'd welcome the opportunity. Absolutely.
Thanks for that, Matthew.
Thank you, Chair. So just thinking about the discussion about the last slide, which Karen quoted, I suppose it occurs to me that one of the bits of data that this board might wish to see going forwards is a quantification of that. So I don't know if for example we are clear for the BCP area whether or not we spend more or less on community care, and indeed whether or not we have higher than average levels of hospital and emergency activity. So I guess that's it's one thing that we might want to ask the ICB to provide, and I think that it could be quite valuable across the whole of the integrated care system, and to see some of the differences that we've got in our area, which I suspect are there. And the further comment I would make, which may not be so relevant to the services around here, but when you look at community care in the NHS context, there's also a question about what you're spending your money on. So in the Southwest in general, and this would apply more to the Dorset local authority area, we spend a disproportionately high amount of our community services money on community hospital beds, and therefore we've got less money on average in our teams that can go and provide care in people's homes. So just having some of that data and seeing how it changes over time might be helpful for this board.
Yeah, thanks for that, and actually thanks, Sam, for your comments as well, because I think that does focus for me, just in terms of my input, is about that governance and scrutiny of this sort of 5-year plan. And there's really good sort of ambitious sort of targets there about preventing 55,000 children from becoming overweight, and all those sorts of areas, and the sort of healthy life years. But it is, in terms of, like you say, the Health and Wellbeing Board holding you to account on that. But also, I don't want to have sort of duplication. I don't want the Integrated Care Partnership also saying, oh well, we need to look at this as well, and maybe our health and Adult Social Care Review and Scrutiny Committee saying, well, we want to have a report on this, we want to look at that. I think we don't need bodies all over the place saying this looks really good, actually can we get some numbers on that, and we want to look at whether you're delivering what you need to deliver. So I think it's, for us, it's probably partly thinking about structures and governance and making sure we do that in one place, where we've got all the right people to sort of to sort of ask for updates and figures and quantification of the work that's going on. So yeah, for me, that's the sort of question I've got in my mind, to make sure that we sort of do that in one place and don't have it duplicated. It's done in Dorset, it's done in BCP, it's done by this body and that body. Yeah, that's my sort of comment on it, really.
Thank you.
But I'm sure you'd shout if you had said, well, hold on, I've just been asked to go and present those figures to that group and that group.
Right, yeah.
Yeah, yeah. So, okay, thanks for that. So if there's no other questions, then I think it's just for the board to note that. So thank you, Ashley, for that presentation. That was useful, very informative. On to agenda item 10 next then, and I think, yeah, we're keeping quite well to time, so I think we're hoping we conclude the meeting within the 2 hours. So BCP Access to Food Partnership update and working together to address food insecurity and improve wellbeing. I'm looking forward to this particularly because I've heard bits and pieces from colleagues about the partnership from time to time, but yeah, and I had looked through the report. So is it for Amy and Alistair, if you can present?
Thank you, Chair, and thank you everybody for the invitation. It is great that we're able to bring this back to you a couple of years after we first talked about it, which in very different days of 2021. And whoever did the agenda here is a genius, because this all sort of fits together in a beautiful way in terms of talking about, you know, I remember when we used to talk about asset-based community development and the 3 lanes thing. Do you remember the 3 lanes thing, which was, you know, everybody has there's a sort of for those involved in expert delivery and statutory delivery, there is a lane for those of us who are at the front line with community thing, and then there's a lane of collaboration in the middle. And this feels like one of those opportunities when we're bringing it to you as in your roles within the Health and Wellbeing Board, where you see, the membership of the Access to Food Partnership is made up of sometimes really small organisations, maybe even not even charities, some of them just groups who are working together in their street or in their particular cohort of people. There are what we're going to do together, you've got the report, we're just going to give you some highlights. Amy and I are going to dovetail back and forward about some of those. And it's right that we should thank Amy and Daisy Carr, who's put together this presentation, who is the Access to Food Network coordinator, who's really a gift to us in terms of her abilities. And we should also thank the lottery, because without the lottery we wouldn't be able to pay for some of this. So we're grateful for that. The steering group, of which we are just but 2, represent a whole range of different organisations who are part of the places you can see on the screen there. And they are made up, the Access Food Partnership is not just food banks, it is community pantries, it is community fridges, it is community meals, it is a group of people who might be growing food, it is people who are teaching people how to cook. It's a whole range of organisations. And one of the things that is really important to say is that that vision at the top of your screen there is really important for us to understand. This is about food insecurity. Though food waste is a really important challenge, our food partnership here in BCP is not explicitly about that. It is about food insecurity and how we can help people to get to that point of resilience where they can feed themselves and their family nutritious food all of the time. And that's been our setup all the way through this. It is worth saying, if we go to the next slide, that there's a sort of a bit of, I don't know whether it's just me, but there's a little bit of a feeling out there. It says, oh, it's a lot better than it was. It's okay now. We're all through that. It was really difficult. We had COVID, and then we had the cost of living, energy crisis, and all that sort of stuff. I just did some quick checking up of the numbers for the last quarter, just in the food banks that FaithWorks runs. And Q2 this year compared to Q2 last year, we gave out 14% more parcels to 7% more households in that period, which says to us all those numbers you can see up there. You know, the number of debt issues that the Citizens Advice team locally are seeing has doubled. You can tell that just the cost of living is still going up. Inflation is still inflation. And if you take those numbers around the food insecurity within our BCP area, that equates to about 25,000 households who are on some form of food insecurity, which is a rather large number. Far too large a number. So it is still a challenge. And that challenge means that when you look at demand versus supply. We always talk within the Access to Food Network about what's going well in terms of supply, operations and demand. Demand is still significant, and yet supply of food, you know, those wonderful drop-off points that the general population are fantastic at providing food, but it is actually dropping. Now, whether that is through fatigue or whether that is through a feeling that things are better, or just it's really hard for everybody, then actually the amount of food that we are having to buy at pantries and food banks, you can see, is getting close to £300,000 in the last year, which is not where we want to be. It doesn't make a lot of sense to buy food to give food. But that is the reality of where we are, that demand is still high and supply is not as it was. So what is the Access to Food Partnership about? As we said, that goal of resilience for people, but it starts, if you like, with where we are meeting people at a point of crisis. And actually, that is the real essence, the benefit, actually, of some of the partners we've got in this group. That they are meeting people in a trusted place, a safe place where people go, actually, it's okay for me to tell my story here. It is so common that it's now, we must avoid it being overcommon, that people walk into some of these settings in any sort of context, and within 10 minutes they are in tears. It is not the old days where, here you go, come into a food bank, there's your food, see you later, off you go. This is where, if you go into most food settings now, you will find somewhere where people can sit and have a cup of tea. They will talk to one of the volunteers and just chat about what's going on in life. Yeah, we'll be sorting food maybe in the back or in another area. But actually, for many people, that point of crisis is where they can start to say, this is how it feels. And of course, the problems are then multivarious. So we talk about the wider determinants of health. That's why it's a splendid follow-on from what you were saying, Ash. The wider determinants of health are just falling out of this in terms of the issues. Food is often, just as we've said for so long, is just at the tip of the iceberg. So, but across there, you can see the first one is about access to food when in crisis, but some of the others are then about equipping people so that they can cope and can find that resilience. And it isn't just about giving everybody an air fryer, though that can make a real difference for some people. It's actually about building the confidence in. So it is great that we have organisations like the Friendly Food Club who are able to provide training in cooking, but often it isn't called training. It's simply sitting down with some friends to actually do a bit of cooking. And that means that people feel, actually, I'm just with my friends here. And so there's the relational benefit as well as the material benefit. We need, so there's a resilience bit, but there's also so much of this which is about communications. How can we help people? I'm going to come on to this in a minute. How can we ask you and ask as many of the population to say, if you know somebody, this is how they can find help. And if you are not in that particular need at the moment, this is how you can help. So there's a whole thing about how we can share a good information, and then the bringing local communities together to identify needs. I wish you could have been to some of the forums that we have where people just sit there and they tell stories. And we talked about one within the overall Access to Food Partnership summary of the year. We talked about the slow cooker story of how a slow cooker has utterly changed a family's life from end to end. But you can see in either make access to food priority, local policy and decision making. That's why it is so good that you have invited us to come today, because that's part of the preventative elements of this. Because there are other elements, by making sure that people are aware of what's going on, but there are other elements that together we could actually use those points of connection maybe to help in a whole range of different ways, which is going to then have more impact upstream in the wider determinants of health we talked about. We often talk about food being everyone's problem and no one's problem, because nobody has it written, apart from Daisy Carr, nobody has it written on their door to say, this is my job, is to help with food, because it impacts all of the people that we are working with. So we need to build that network to make it strong. But it's what we want to do is to share with you, it's okay talking about a partnership and that all sounds very nice. What actual difference does it make? And Amy is going to share some of the stories that we've had over the last year.
Thanks, Alistair. Yeah, so just building on the great things that Alistair said. So the dedicated coordinator that's in post really helps to facilitate that network. we enable the sharing of knowledge, but also thinking about how we can inspire further development and improvements within that network. So through the forums, newsletters, and then creating things like neighbourhood conversations around things as well. And then we provide the partner resources behind it. So looking at the training, looking at we've got a food support map that I'll talk about in a minute, and also access to funding to be able to help with arising issues and very grassroots level work that's happening. So the partners have strong relationships and work really well together. So they really understand what others are doing so that they can really effectively connect across the partnership and the work that's happening. So focusing on that crisis prevention and resilience. And the partners are really agile and flexible in their approach as well. So they're always looking at how we can evolve. So just going through a couple of examples to give you a bit more, I was going to say flavour, but that's a bit of a pun. But one example of building the resilience has been focusing on that cooking support. So in response to the concerns that we've been hearing from households around people worrying about turning their ovens on because they're worrying about the rising costs of energy bills. So in response to that, we brought partners together and we looked at how can we use the arising issues pot to be able to distribute air fryers and low energy cooking equipment. So the projects were able to provide that equipment, but alongside it, they were providing the cooking demos and sharing recipes to build the confidence around using that equipment. And then in addition to that, that's led to more partnership working where we've they wanted to avoid the duplication of lots of partners coming up with recipes by actually coming together and collaborating to create a Let's Start Cooking Together recipe book that's used with residents alongside that work. In Winton, there's been some great place-based work that's been happening. So they've been able to create 2 local voucher schemes. The first one's been working with local butchers and greengrocers so that those that are visiting food banks could then shop in their local high street. So being able to use a voucher to be able to access fresh meat and veg. And then the second voucher scheme has been working with local parks to offer families a day out during the school holidays and using a voucher to be able to enjoy a free ice cream or refreshments in the park activities so they can feel connected to their communities and able to share with their families. So it's also about sharing good information, and the Access to Food map is a really important resource for us. It shares over 80 food initiatives and is available across what's available across BCP, and it's used by frontline workers alongside the public. It's had over 40,000 views, but we still need more people to know about it. So I've added the QR code here on the slide, and we hope that you will access it. And we'll also would like you to encourage and promote it with your staff as well so that everybody can use it. We're also really pleased to see that we started this map some time ago, and it's nice to see that it's been replicated in other places across the UK. And alongside it, we've also done things like create information posters, done translation of information on the posters into 8 commonly used languages, so that's been distributed across over 250 community venues so that we can share that information with diverse communities and those not able to access this information online. So this is another example of working together. So in response to last Christmas's challenge, where there was a surplus of frozen turkeys on Christmas Eve and lots of volunteers racing around to the early hours of the morning to try and redistribute them, we planned ahead for this last year that's happened, and we worked together to create a shared storage space so that we could better respond to that last minute surplus. And this was a really great example of how we started to deepen our working relationships into more formal agreements. We've also done survey work with the partners to understand how it's important to them, and there's been some really positive feedback. And as Citygate, one of our partners, explained, through the partnership, they feel connected, resourced, supported and understood. And it's really enabled partners to feel that they can do more. So food banks being one of those examples about providing much more than just the food parcel, as Alistair said, but thinking about the example that I gave earlier around the cooking project. I also mentioned the access to funding. So the Grassroots Kickstarter Fund provides really small pots of money of up to £500. That might be something that you wouldn't be able to pick up through another funding scheme, but it really helps to support that micro level work that's happening and taking place. So a couple of examples of that would be the setting up of a community fridge in a local school in Kings Park Academy, and also helping another group to buy equipment to set up a new community allotment. So small things, but big difference to people. And we want to continue to strengthen our connections across the ICS to create a stronger system that can respond to crisis prevention and building resilience. So my team also leads the Together We Can partnership, currently working with the cost of living support, and as well the Age Friendly Network. And Alistair is helping to lead on the homelessness partnership work. So we like to connect with other partnerships. Over to you, Alistair.
Thank you, Amy. It's really great examples you've given there. So this really just summarises where we've got to. The recommendations are in the report and we can come to those in a moment, but we would really like to hear from yourselves as members of the Health and Wellbeing Board, what stands out for you, whether there are questions on what we've been doing. There are clearly things that we would like to ask you in terms of whether your anchor institutions could help with that whole problem around supply, increasing local donations, or even creative ways in which that we could work together, maybe in different settings. We would love to discuss with you that whole way in which we can help to inform your workforce, your frontline workforce, about this, that what is available for some of the people that they are working with. And we'd also like to really help and see if we can understand better the pathways that people have to sometimes go through. It almost seems the wrong type of word for this environment. It seems too techie a word, but that idea of where is they going to get the most help? What we don't want to do is people just handing out food bank vouchers as like confetti, but we want to work together more effectively, maybe with some of your teams, so that we can understand how to make that really we called it their Better Referrers Project, but how can we make effective referrals? So there's a whole series of information there. Before we go on to the recommendations, Chair, I wonder whether we could stop at this point and just see if there are any questions or comments from members of the board.
Okay, thank you for that, Alistair. Yeah, any particular points that you want to raise following that? Matthew, yeah.
Great, thank you. So I thought that was an amazing presentation about incredibly positive work. From the point of view of the organisations I work with, we'd love to be involved. So I know that this is an issue for actually some of our staff, as well as some of the groups, some of our patient groups. At the other end of the scale, I recently spent some time with our homelessness team in the BCP area, and obviously that shows up for people on the streets as well. So we would love to be involved and also give you access inside our organisation.
That's fabulous to hear. Thank you, and we will. We'll aim to follow up on that as soon as we can, if as a starting point for your wisdom to show us where is the best place to have that initial conversation. Thank you.
Thank you. And I think you highlighted as well about that hidden hunger that many people are in work and are still struggling with the cost of living. So it's unfortunate that situation exists, but it's good that you highlighted it. Thank you.
Thanks for that. I've got a couple of people indicated online. I'll come to you short in a minute. Sam.
Thanks. Thank you, Chair. Great presentation, Alistair, Amy. Just a couple of quick points, really. I think that model of empowering communities to do things for themselves is really, really powerful. But I do think the public sector need to find a way of making sure that we're investing in the infrastructure so that there's the basics in place and good connection to our statutory organisations so that that can continue and it can flourish. So I'll just put that challenge out there. So that final point on this last slide, I do think we need to talk about longer term resilient funding. The other point I wanted to make was I was really struck, Alistair, when you were describing the way that teams are working in these community spaces and allowing time for people to unpack what's going on for them and just listen and provide that sort of safe space, if you like. So we previously had a bit of a conversation about the work on integrated neighbourhood teams. I think there's a lot that those teams could learn from that different way of working that allows people to explain what might be going on in the whole of their lives rather than perhaps sometimes the way that we work as professionals, which is just being interested in the presenting complaint, if you like. So perhaps there's a bit of two-way learning and two-way sharing that could go on from this work. And then my final point was just to raise the issue. I believe that the whole of Dorset has been awarded accreditation to join the Sustainable Food Partnership. So just to kind of make that point really, that the work continues. I believe that you're working very, very closely with organisations in the Dorset Council area as well, and it's great that the Pan Dorset approach has been recognised by that accreditation. Thank you, Chair.
Thanks for those comments, Sam. Next, I did have Kat online, actually, if you wanted to.
Thank you, Chair. Good afternoon, everyone. I'm Kat McMillan. I'm Head of Community Engagement and Community Safety. I just want to thank Amy, Alistair and all of the partners for the incredible amount of work that takes place. They are drastically underplaying the amount of work that takes place through this partnership and trying to summarise it in a sort of an 8-minute presentation, and it doesn't do sheer justice to the amount of work that takes place, including national award-winning recognition of the partnership. So I just wanted to highlight that particularly for the board. But my point, I would be really interested in us as anchor organisations thinking about how we change our language around food insecurity. We're all very happy to talk about mental health in the workplace. We're very happy to talk about domestic abuse in the workplace, supporting our colleagues. How can we shift that to start talking about food insecurity in the workplace? And what is our role as those anchor organisations to take that forward, please?
Yeah, that's a useful comment. Thanks for that, Kat. Something for us to think on. Siobhan, you indicated.
Just Amy and Alistair, it was just really inspiring listening to you. It was incredible. Incredibly sobering, really, and the fact that things are actually getting worse. But it did make me just reflect a bit, because we are talking about teams, we're talking about actually the complexity of people and organising teams. And actually what you described, there was a certain simplicity to it, and I'm sure it's not simple, but the way you described it was incredible. And actually you've created a sort of ecosystem around this. And I suppose there's just a question for all of us about how do we connect into an ecosystem with a culture and a philosophy which seems incredibly person-centered. And I was thinking at UHD, you know, we have a staff app. So, you know, on all our mobiles, we've all got a UHD app. Actually, how do we just create something very simple that connects what we're doing with what you're doing and that QR code, etc., etc. So I'm really happy to follow up outside. But I think if you think about what you've just described, the challenge for all of us is probably to think, how do we replicate something, or not replicate, because you don't want to replicate, but how do we come together and utilize some of the sort of ecosystem that is already there and build on that in this part of town.
Thanks for that. So I just have Kathy as well. So
Sorry, just to say it was a really inspiring presentation, but also I think, as Siobhan says, it is relatively scary thinking about the figures and the continuing of that happening. And I know in staff groups we've had discussions about the economic situation we're in and how people who in work are really struggling, and how difficult sometimes that is for them to say or to seek support, especially from an employer. And so there's a bit for me is about how do we ensure this is an offer across the workforce to start off with, and then how is this an offer for the workforce to get engaged in supporting this on both sides. I know from Children's Services we've had a number of presentations on this, and there is a level of engagement, and on there we talk about family hubs and how we make sure this is part and parcel of the information giving in family hubs. I was just interested where we've had penetration in schools, academies, trusts, both giving information out but also supporting families. And I'm not sure whether there's a space for us in the education skills area in children's services to get involved in that, to promote that with head teachers. We do a 3 weekly coffee morning, you know, all those kind of things. So more of that. So is there any space we can step in there for you?
Alistair, yeah,
There's so many great points you made there. We'd love to respond to them. Amy, could you just talk about schools? Because there is some good work going on with schools, isn't there? And then I'll come back to all those things.
Yeah, and we were doing quite a bit more during the COVID period as well, where we were hosting information sessions and head teachers and others were coming along to that, and they have engaged in the network, but we would like to continue to sort of get breadth alongside that. Also through the Household Support Fund, we've been distributing the school vouchers and working really closely of relying on them as a trusted partner of understanding their families to be able to distribute vouchers, which I think is quite a nice model again. So yeah, it's nice to build on that. There's still lots of work to do, so it'd be nice to be able to do that. And just picking up on your point, Siobhan, as well, I think it really builds on the Poverty Truth Commission and the principles that comes out of that around the humanising the process and just actually like responding in a human way to people that are in crisis or prevention. And I think you sort of were hinting on that, and I think a lot of those principles come out of Poverty Truth, which Alistair was involved in again. So, so yeah, thank you.
Just to build on some of those other points, Kathy, you make a great point. Within our, we didn't write this before, just now, but within our priorities, one of the first things we've got here is support schools to identify early signs of food insecurity. It's great that, you know, Poole Food Bank is connections with 32 pastoral workers within schools, but there's a lot more we could do, because there are some fabulous examples of where schools, we mentioned Kings Park there, are doing some very creative things with their families, not just with the children, but with their families. And I think there's more that we could do on the back of that. If I could just pick up a couple of the other points, it's so good. You mentioned the in-work issue. We did, with the stats we've got at the moment coming from some of the food banks that FaithWorks runs, is somewhere between 16 and 20% of the people who show on their voucher, because not everybody does, are in some form of work. So this is, I'm really pleased that you're recognising this as an issue, because it is a reality, and there's an absolute two-way thing we could do. You know, for those people, making it really easy for people not to feel any sort of stigma that they have to put up their hand and going, actually, it's a bit tricky right now, because, you know, if your boiler blows overnight, you probably haven't got any cash to be able to deal with stuff. So it could happen to anybody. But I think the other side of it is getting things like the Bank the Food app, which I said I wasn't going to talk about, but I do, which is a fabulous app, national app, where you can put in your local food setting, and it will even buzz you as you walk into a supermarket to tell you what you need to buy for that food, for that particular food setting. So there are some nice things that we can share around that. Yes, indeed. Sam mentioned the Sustainable Food Partnership in Dorset. We have connections with Help and Kindness. Indeed, they are coming to our next forum, I think, in September, to talk a little bit more about that and how that connection means. So there are some useful connections to be made across that. I think the final point is, for me, is Siobhan, you made a great point about how we can learn from each other. I think one of the things that we need to try and find a way of doing is a lot of the operations, a lot of the individuals, tiny organisations, some of them, what they don't want to be doing is suddenly trying to fit into, or where do I point myself to get help? What's really nice is where you see, I'll big up Shelter. Shelter have been great at just coming into some of the settings and sitting there and having a chat with people about housing issues, or somebody from, I always forget the name, the energy people. Ridgewater Energy, who come along to settings and just talk about how people can make sure they're getting the best energy deals. Those sorts of partnerships are fabulous, and if we can find ways of doing that better with some of you around here, that would be amazing.
Yes, to all of that. I just wanted to say that all of this is not possible, and we're part Community Action Network are an active part of the partnership, and I noted 83 now settings, but most of this is delivered by volunteers. I would say, who are good people and true, just giving up their time. And I think it's really important to say that doesn't just happen. You don't just happen, people just don't volunteer, find a way to volunteer. Small community groups just don't pip up, or even the big ones like Waste Not, bigger ones maybe, like I'm going to perform Waste Not, Want Not on Paul High Street. That, you know, we were there with them shoulder to shoulder, helping them set up, making sure that they're safe, that they've got good governance. All these things really, really matter. These people are maybe not being paid, but then they are maybe amateur, but they are professionals. They're just not being paid. But it's really important that there is support there for these groups, to support their infrastructure and support them to happen, because the return on the investment is huge. So I would be remiss if I didn't do a little plug for us in the background doing that, given that investment in infrastructure has much depleted this year, much depleted. So I'd be remiss without saying it's amazing what happens, but it wouldn't happen without having that support, I think, up behind it.
Okay, yeah, no, thanks for that. It's an important point. I haven't particularly got much to comment further than what all the other useful comments we've had, other than the points for discussion. You did say about the last one about the longer term funding for the food insecurity work, and I know obviously the lottery funding that you've got is a 3-year funding, runs out next year. Yeah, so I guess that's the
So there's one more year of funding for that. So yeah, and that kind of funds around the coordinator, and with the dedicated coordinator makes such a difference in terms of being able to really focus on the work, and then also things like that grassroots funding and arising issues and things behind the scenes, and being able to fund that. So it's really important. But yeah, it's difficult to not have a longer term sustainable approach about investing in it through the system as a whole.
okay, and I'm sure some colleagues, particularly in our community area, are aware of that. So yeah, I think that's something we need to sort of keep our eye on. I know there's a number of recommendations we've got before us. Some are fairly straightforward. For me, when I read through the recommendations, I think it was recommendation D, particularly about recognising your role, but committing to ensuring that the frontline workers have up-to-date knowledge and understanding of the Access to Food Partnership. I think that's something, you know, within our organisations we can really actually sort of take on board and make sure that, you know, we've got hundreds of frontline workers across the different areas represented here. So I think that's one particularly for me that's sort of very relevant for us as a health and wellbeing board to sort of be able to take forward.
Chair, could I just respond on that one? We really welcome that. Thank you. What would be really helpful be to have maybe a point of contact. I know that's hard with organisations, but to find that person who could be the flag holder in your organisations would be immensely helpful.
Okay, I think, yeah, if we can all take that back.
A Community Action Network run a virtual hub professionals network for our adult social care colleagues, and now our children's social care colleagues and children's services colleagues. And on that, we've got all the information about the Access to Food Partnership to help link in. We've got over 5, in fact, we've reached the limit with our adults. We need to look at innovative ways to do it, because teams have been funny. But that's a fantastic way to make sure that those frontline workers can ask questions, get peer support, find out what's happening. And that has been, I'm looking at you, Beth, that's been hugely popular, hasn't it? They've been, it's really works, because that's people talking to people, that stuff. But it's all very much connected in there, very much so.
And I think for me, it's particularly about where we were talking just earlier about integrated neighbourhood teams, and where we're looking at that sort of model and place-based. That's where it links in very closely in terms of, you know, knowing the contacts at the food bank and the different organisations within those localities and those neighbourhoods that are going to need to connect in with. So, okay, we'll ask the board, you know, if we obviously accept the recommendations that are there. It seems like I need to move on for time purposes, but we could go on talking for a long time about what you've had to present, and thank you very much for coming along, both of you, to present to us. And I think we've all sort of taken something out of that we need to take back to our sort of offices and act on. So thank you very much. Right. And as you said, actually, I think the structure of the meeting's been very good, actually, talking right from NHS plans down to the access to food partnership, and pharmaceutical needs assessment is the next bit. I've got Sam online to present here, and I know you've got, obviously, hopefully we can just run through this one in about 10 to 15 minutes, Sam, and the recommendations that we've got for the board. So over to
thank you. Thank you very much, Chair. I don't think this will take much time at all, but I have got a couple of key questions that I'd like to seek the views of the board on. In summary, this paper is very much just about introducing the start of the process for preparing to deliver a refreshed pharmaceutical needs assessment. And just for members' background and context, this is a statutory responsibility of each Health and Wellbeing Board to prepare and publish a needs assessment that governs what we understand about access and provision of pharmacy services. Has to be reviewed on a regular basis, and the point of the needs assessment is really to support the NHS Commissioner to govern market entry really for pharmaceutical services. So it doesn't comment on the quality of pharmaceutical services, but it's concerned with making sure that we've got decent coverage across the population. So it'll make an assessment of where pharmacies are, the sorts of services that they're providing, their opening hours, and it will also collect comments through the engagement process about how well we feel the population is able to access those services. We're supposed to be making an assessment of where there might be gaps in the coverage of pharmaceutical services. And one of the issues I wanted to raise with the board today was that in the past we've used national guidance to make an assessment of whether there are gaps in coverage. The national guidance usually uses a sort of rule of thumb of a 20-minute drive time. However, we've been made aware that that may not be appropriate for all populations, particularly if we're looking at this right the way across Dorset, including the Dorset Council area. So members may be aware that there have been pharmacy closures, particularly after the pandemic. And in a couple of instances, we've been having conversations with the community about the closure of a branch pharmacy and concerns raised about physical access to the remaining surgery. This is actually a pharmacy on Portland rather than in the BCP council area, but it brought the point forward that sometimes when we talk about access in terms of car ownership and drive time, that probably doesn't apply to everyone in the population. So we need to think about other ways of discussing access to services and including access to online pharmacy services. Not everyone is comfortable accessing online services. So it's really just seeking the support of the board that they're comfortable that we will be broadening the conversation on access as we go through the next stage. In the past, we've worked jointly across both Health and Wellbeing Board areas to prepare a single pharmaceutical needs assessment for Dorset. It's quite labour intensive in terms of the information that we have to collect and the way that we process that. The steer in the paper is that we'd very much like to continue to work in partnership between the two Health and Wellbeing Boards just to improve the efficiency of the way that we run that process. So one of the questions that we're asking the board to consider is whether you would support us continuing to work together and produce a single pharmaceutical needs assessment for the integrated care system area. And then the other point I was just going to draw board members' attention to is that we do like to consider provision in smaller geographies rather than just the kind of high level integrated care system geography. We're going to propose looking at pharmacy provision on a local basis using the emerging boundaries of integrated neighbourhood teams. I think that will potentially improve the discussion about the integration of services going forwards in that very, very localised area, if you like, and particularly relationships with other primary care services. One of the big changes that's facing pharmacy at the moment is the provision of what are called pharmacy first services. So NHS England is increasingly looking at the provision of a much wider range of services on offer from community pharmacies, partly to help with the increasing demand on primary care as a whole. So I think this next iteration will be talking much more about some of those new services that are available in pharmacies. And again, having that sort of local context as we do the engagement will be important. So just to go back to the paper, it sets out a proposed timeline for delivery. We've proposed initial membership of the steering group that will sort of oversee the process. And I think we're just looking for support today to continue to work jointly. Recognising that public health is going through a change, I think it would still be helpful if we could collaborate on processes like this, if the board is in support of that. So I'm happy to pause for any questions before then going formally to the recommendations, if that's helpful, Chair. Thank you.
Yeah, thanks very much for that, Sam. Yeah, any questions on those points? Looking around the room, it looks like everybody's content with what you presented, Sam, and don't have any particular questions. I know in the timeline, obviously, the Dorset Health and Wellbeing Board has considered it. Just to clarify, were they content with a joint sort of pan-Dorset assessment as well?
Yeah, they were content to work together with the BCP Council Health and Wellbeing Board. They were very interested in this issue about trying to understand access from different dimensions and different population groups, possibly because it's a more rural area, but that was a big thing for the board's discussion. I noticed Kat's got her hand up as well, Chair, so I'll take Kat's question.
Thank you, Kat, if you want to.
Thank you. It wasn't a question for Sam. It's more a affirmation that fully support that proposal. And I'm not a board member, sorry, I'm butting in, but fully support the proposal about consideration of those communities most at need, and particularly those with the highest health needs and ability to access transport. If I think about Boscombe, it's got the lowest car ownership across Bournemouth, Christchurch and Poole, highest health needs. I know it's well served currently, but I'd want to make sure that was taken into consideration going forward in terms of provision. So fully on board with what Sam's proposing there. Thank you.
Thanks for that. Any other comments, Gillian? Did you want to?
Yeah, just to endorse Sam's recommendation in there that this is done on a pan-Dorset basis across both health and wellbeing boards. I think that makes a lot of sense, and also the connection you've made into the emerging integrated neighbourhood team footprints, I think is really helpful, and it will bring them to life in lots of ways and provide a real focus for those emerging teams to work around. So that's a good connection, and a good connection showing how effective the agenda has been as well. So thank you.
Okay, thanks for that. If there's no other comments, I know there was a couple of points there in the recommendations, wasn't it, about considering the scope, etc. But I think the few comments we've had there cover that hopefully for you, Sam. Yeah, certainly I'm content with it being sort of the pan Dorset, and you do make a good comment about the integrated neighbourhood teams, and it does seem odd, doesn't it, the sort of arbitrary 20-minute drive time, which is it's very different from different communities and different geographies. So yeah, I think if all board members seem content with the recommendations we've got for us there, everybody's nodding, and I won't go for a show of hands, but I think everybody's nodding in affirmation of those. So is that all you need from us, Sam, in terms of?
Yeah, I think that's really helpful. There's perhaps just one final comment which I failed to make when I was introducing the paper, but I do tend to make it just for clarity, which is that the statutory responsibility on the Health and Wellbeing Board is just to prepare this assessment and then to comment on whether we believe there are any gaps in provision. It doesn't mean that the Health and Wellbeing Board has statutory responsibility for commissioning or provision of pharmacy services. We support the NHS in making that assessment to support their commissioning decisions in how those gaps are closed, if that makes sense. Sometimes there's a bit of confusion about the role of the Health and Wellbeing Board in this process, but I just wanted to make that clear that we support the commissioners in preparing this assessment.
No, that's really helpful. Thank you for that. Okay, if there's
Great,
no other comments, I know, Sam, you've got other places to get onto, so thank you for that, and we'll move on to final main agenda item 12 on the Better Care Fund 2023 to 25. Phil, I know you're here to talk us through this one.
Thanks, Chair. And just for those who don't know me, I'm Phil Hornsby, Director of Commissioning for BCP Council. And I'd love to say this was all my own work, but it isn't. It's been done by a number of people across BCP Council and NHS Dorset working together to both deliver the Better Care Fund plan and the outcomes that are contained within it. Just a really brief summary, because the paper contains quite a lot of detail, and I just wanted to pick out a few points. So the report's got several elements in it. It's got the reporting that we need to do back to NHS England as part of the conditions of the Better Care Fund. And it's got Q2, Q3 and the year-end report. And apologies to the board, but it's just been a clash of either the business cycle of both the board and NHSE's requirements, but also the general election got in the way slightly and we had a cancelled meeting. So you're receiving a lot of papers all in one go. And in some ways, that's not a bad thing because you can see the trends and the journey from the templates attached. So the other part of it is the 24-25 planning template, which sets out the funding allocations and the performance metrics for the year that we're currently in. It doesn't change the schemes that are funded because it was a 2-year plan. This is the second of the 2 years. But what it does do, it alters and adjusts slightly some of the funding across the schemes and some of the performance metrics. But in respect of the quarterly updates and the end of year performance report, the report does highlight the targets were met for the rate of permanent admissions to residential care, and the lower the number of those, the better. That's the target is to keep those as at a minimum where we can. The percentage of people discharged from hospital their normal place of residence. So did they go home, whether home was a house they lived in or a residential care setting or somewhere in between, such as extra care, but their place they would normally live. And we did really well, and that we had a 95% return rate. So that's good, and that's a good reflection on the work of the partnership across health and social care and housing, of course. Excuse me. And then the proportion of people who are over 65 still at home 91 days after discharge from hospital into reablement or rehabilitation. Now, we met the target, but it's one of the areas where we want to challenge ourselves, and we're doing work currently about how we can increase that performance and work even better together, and very much across Matthew's teams and social care operational teams and our local authority trading company, Tricuro, where we're trying to work much closer together to wrap around people and get them home. And it's, of course, a particular interest to Siobhan in terms of getting people out of hospital in a timely way. So we do, whilst we met the targets, we do see there's a challenge there to increase that percentage number beyond where it currently is. There were 2 areas where we didn't meet the targets. That was unplanned hospitalisation for chronic ambulatory care sensitive conditions. Quite a mouthful. What that means, it's long-term conditions where normally you'd expect people to be supported in their community by primary care, community health and community care services. And the examples of that might be diabetes, epilepsy, high blood pressure. So things that are not unusual, but could be managed in a person's own home most of the time, or in outpatients or in the GP practices. So some work to do, and we know there's been a lot of pressure on those services running up to and since COVID. And the integrated neighbourhood teams is a good example of how we might work better together to address some of those issues. And there are also plans to reduce the numbers in things it's included in the report, but by the use of things like virtual ward and also just thinking differently about how we support people in the community. So looking at the 24-25 plan moving forward, as I said, this is the second year of the 2-year plan, and we've aligned the money slightly differently to focus it into areas where we think there'll be the most impact. And if you look at the finance figures, you'll see it's increased. The value's increased from about 71 million in total to 75 million. And that's the inflationary increase that government and NHS England set for the system through NHS Dorset to increase the minimum contribution by a set percentage. And that's balanced across a significant amount to meet adult social care, support adult social care to meet its requirements, but also to support hospital discharge. So there's a real focus in the plan itself, but also the overarching requirements that funds high impact changes to support people out of hospital or prevent admission to hospital or other long-term care issues, but also to support carers. And the other element is the disabled facility grant, which supports all ages, families, adults who are working age or older people, where they made adaptations or changes to their home to enable them to remain independent and reduce the need for more institutionalised care. I'm conscious of time, Chair, so I'll pause there.
Thanks for that summary, Phil. I know there's a lot of numbers in those various reports. Any questions or comments or points that members wanted to raise? Siobhan, did you want to?
Thanks, Chair. Thanks, Phil. Do you know what I would just like to say? Because that report, I mean, obviously it's a template. There's loads of detail in there, and oh my gosh, the amount of work that has gone on. And as you say, it's good to see the trends. I suppose it's a question for me for the Health and Wellbeing Board about actually how do we bring this to life and make it something that publicly it is quite easy to understand, and that actually the outcomes and the measures that we're looking at are something that when we're in a public forum like this are really lived experience. It's some of the storytelling that we heard earlier, but also at the moment these are very dry numbers, and I just think it would be good for us maybe to get together and think about, and I know maybe the ICB is doing this and you can tell us if they are, but actually how do we bring this to life and make it very real, because it should be a sign of how well the partnership is working if we get this right.
Yes, it is really dry, and I think that's a really good idea, Siobhan. I think we can bring some examples back. I think within this standard reporting, because I knew that the agenda was quite busy, but I wonder whether future board would want to hear examples of the joint working we do in particular settings, or the work that Healthwatch have been doing alongside us to try and understand the voice of the person and what their experience was. Not necessarily we've done all this good stuff together, but how did they feel on that journey? What did it feel like to them? What would they change?
Yeah.
I'm just thinking about our sort of boards. We bring stories from patients and sometimes staff, and actually it may be, Chair, that we could consider bringing some resident stories to the Health and Wellbeing Board, because it would really ground us in what we are about. It's just worth thinking about.
Yeah. Gillian, did you indicate?
Yeah, thank you, Chair. Just a question really about, I mean, these funds have always been critical, but as our collective funds across the system are more and more under pressure, that these become more and more critical. My question is, as we're looking ahead into autumn, winter, as we already are, aren't we? Especially with the weather today, it almost feels like we've got there. How flexibly are we able to deploy these resources so that we just keep focusing them on the priorities?
Not. It's set. It's a plan that is set and we're measured against, and there is no flexibility to do things in year. The only time you can change it is to review it, and we're expecting perhaps different planning conditions. For example, they're going to change the people still at home after 91 days measure. They've been promising to bring that revised set of metrics out for about 12 or 15 months now. But we want something that's a bit more tangible, and it comes back to Siobhan's point. Is this something that would allow us to go, well, we found this is working differently. Can we just move in year and do something different? But there's, as you see from all of the data that's there's a set target, what your planned activity is, what your actual activity is, and therefore what was your expenditure against that. It's really quite restrictive. That's one of the concerns we have with it. It doesn't allow you to do what you might need to do most in the system.
No, and I tend to agree actually with Siobhan that there's an awful lot of data in here, and there's obviously an awful lot of work gone into sort of these reporting mechanisms and monitoring, but it's something to bring it to life. And I appreciate your points about this is where actually things are looking better than we'd anticipated, but then there's other areas that we need to work on. I think it's some for me it's something around those and around is delivering better care in individual cases of where these funds have actually delivered better care and actually made a difference in people's lives. But Kathy, do you want to?
Thank you, Chair. I think it would come alive if there was an element of impact and outcome, but I do understand the work that sits behind it, and the fact the plan then has really key performance indicators, but some analysis to keep it live about, well, what is the impact and outcome would be really, really helpful, because clearly there are in some areas and clearly there are not in others. I think I would welcome the possibility at the point that the plan can be reconsidered or reviewed is to consideration where children are in this plan against that better health about the especially around the 18 to 25-year-olds that we support. And so I can't generally see that in this plan. It'd be good to widen that out.
Okay, Matthew.
Thank you. I mean, I would echo all the comments about the immense amount of work that has taken place. I think alongside children, if we're standing back and looking at the outcomes of this, I think I would ask, how is this making a difference for people with mental health conditions? And I suppose with the immense focus on process that there has to be here, do we, going forward, do we also want to see some outcomes about how in BCP, how, I guess the question is kind of how can we demonstrate how effective we're being in this space, and how do we put that alongside what our ambition might be? So in not necessarily in this report, but often we're drawn to a comparison against the average or against the target. Is that right for our population going forwards? And are we maximising the value from the amount of money that we're putting in here in this environment where our resources are so scarce? But please, none of those questions detracts from the immense amount of work that goes on in a really positive way.
Okay. Just in terms of the recommendations we've got before us, obviously we need to recommend the Health and Wellbeing Board retrospectively approve the BCF quarter 2 report, quarter 3 report, the end of year report, and the 24-25 planning template. And looking around, I'm assuming we're all content and there's been no queries on sort of what's within those reports. I think we're all happy with those recommendations. I don't know if there's any other sort of recommendations.
Just coming back about the point about flexibility and the constraints that you've described, Phil, and getting the greatest impact from this. I'm conscious that we do have a dialogue with NHSE, don't we, about pressures. We are at a time where there's a new government in place, and the NHS and performance and these issues will be very high on the agenda. So can we make sure that we are, where there are constraints that mean perhaps this money is working less well for us than it could, that we're feeding that into that dialogue upwards into NHSC and DHSC as well, because this may be the moment where we can have some influence.
Okay, of course we can do that. And just to think that actually you raise a point that we should not hide away from, that this was the Better Care Fund came in 2014. We've only ever known it under the Conservative administration. We don't know what the future will hold, and whether this is the vehicle that the new Labour government will want to continue with. But so I assume that October is a key time when we understand their ambitions and views. So we shouldn't lose sight of that there is some risk attached to this fund as well, because at the moment it's guaranteed income, hasn't changed for the last 10 years, and gone up slightly. We may see a different view, or we may not. We may continue and just change the target areas. And I think there's some very quite rigid planning conditions attached to this at the moment that say what you can spend it on and what you can't. Well, not what you can't, but where it's supposed to be focused. So whilst happy to feed up through our usual routes up to NHSE, we just need to be conscious that there is a certain drive, and we do get challenged on this to deliver against those quite tight conditions.
Okay, Kat.
So I was just going to ask, and do we benchmark the way we structure it against other better care funds in other councils? Because I think from my experience, there's a bit more flex, there's a bit more in some areas, and use of surpluses and things like that we don't kind of look at here.
Yeah, there are no surpluses in the Better Care Fund, but we've been held up for a number of years as an exemplar Better Care Fund plan. So it's not I'm not saying that others don't do it slightly differently, but we've always been held, particularly in the southwest, and always been assured at the first run at it. So, but that doesn't mean to say we can't do it differently.
Thanks for that, Phil. Unless there's any other sort of comments, conscious of time. So if that's what we need, I think everybody's okay to make those recommendations there. We can move on to, we've got agenda item 13, which was the University Hospitals Dorset maternity paper. So that's for information only. There wasn't no proposal, discussion or presentation on that. I know I had a read through and it was quite very informative, particularly when you realise that it's spring 2025 when we're looking at changes coming in. And as you said to me earlier, Siobhan, that means if you're getting pregnant about now, then things are going to be different. So
having a baby at Bournemouth.
Yeah. So yeah, the 9-month planning window is sort of right. Yep, sure.
Yeah, just on that paper, the maternity paper, thank you to Siobhan and her colleagues in UHD for providing that paper. The paper is going to ONS, Overview of Scrutiny Health and Care this evening. I already have had, and it's gone for information as well. I've already had some questions, as you would expect, Siobhan, but we won't be answering those questions tonight at ONS, just noting the chairs behind me for ONS, but we won't be going into those. But what I would say to this board is if there are any further questions, please feel free to send them to me and I will collate them, and then I will be sharing them with Siobhan and other colleagues at UHD. Thank you, Chair.
Great. Thanks for that, Betty. Thank you. And then item 14, the forward plan. Just call it up on my screen. I don't know if we particularly need much discussion or if it's really just for noting particularly. Obviously, there's been a lot on today's agenda to work through because we've had a sort of cancelled meeting and delays with other things. So our next meeting scheduled is the 21st of October. And that's when we'll be looking at the Health and Wellbeing Board strategy and action plan, which is something we spoke about back in February. I know there's potential future items yet to be allocated to meetings. I'm sure some of those or others may come forward for the October meeting. I'm sure we won't just have a one item agenda for that one. Any other points or comments on any other things people wanted to raise that we're going to need to put on either our next meeting or future meetings? Oh, Kat, if you want to.
Thank you, Chair. It's just whether you would like a future report around age-friendly communities to come to the board at some point. So Amy, who presented on Access to Food Partnership, her team also leads on developing age-friendly communities across Bournemouth, Christchurch and Poole. So if you would like to extend an invitation, we'd be very happy to come and talk about that for you.
Yes, that'd be really useful. Actually, I know as members have had a sort of presentation discussion on age-friendly communities. So yeah, I think that'd be useful to come for one of the next health and wellbeing boards, definitely. Thank you. Okay, if that's the only comment on the forward plan, then I think we can okay what we've got on the draft forward plan at the moment. Obviously over the summer things will change and we'll sort of build up the agenda ready for the October meeting. And with that, 2 minutes later than I planned, we can close the meeting. Thank you very much.